the Shelbourne Knee Center podcast. This is Dr. Benner and Scott Bauman. My co-host is here with me today, and today's episode is about total knee outcomes based on preoperative measures. And we did a study with a medical student helping us out, looking at factors that dictated polyethylene insert size in total knee replacement, and wondered if it affected postoperative outcomes. Does it affect postoperative outcomes? So good topic today. I think that a lot of surgeons I hear talk at meetings, and when I talk to friends about surgical technique, really seem to worry about the thickness of the plastic that we put in, whether or not it makes a difference if you use a size 16 versus a size 12 insert. And, we'll touch on that a little bit more, what my own thoughts are about that, as well as what our data shows us. Make sure to look at last week's episode where we talked about total knee replacement outcomes based on sleep disorders. Dr. Femi Burke, a resident physician in orthopedics from Wright State University, did a study with us about that where we looked at preoperative sleep diagnoses and discussed whether or not that would affect postoperative outcomes. So that was an interesting discussion, and I would encourage you to go check that out. If you want to find us on social media, you can find us on Instagram and Twitter at the SKC Podcast. You can go to our YouTube and Facebook pages for the Shelbourne Knee Center podcast. If you'd like to contact us, you can email us at the skcpodcast@gmail.com or go to our website, fixknee.com, and check out more about our clinic.
So yeah, Dr. Benner, as you said, we're talking about another total knee topic today, and I think it's going to be a great one. It's one that we really put a lot of time and effort into to find out some specifics in terms of these factors that lead to different outcomes after total knee surgery. The title of the project was Factors Dictating Polyethylene Insert Size in Total Knee Arthroplasty. Does it affect postoperative outcomes? And this is one project that you led the charge on with some assistance from myself, Adam Norris, and Brittany Sloat. Brittany Sloat's a medical student at Indiana University, which helped us out on this study. So to dive right into this project, like we start with a lot of these and looking at different research projects, what was the rationale for wanting to do this study?
Well, it was a couple different things. One, when I was a fellow trying to learn how to do knee replacements at a higher level, I worked a lot with a lot of different attendings. But Gil Scuderi, who we've had on the show, go back and check out his episode about mechanical alignment and total knee replacement. When I worked with Dr. Scuderi, I remember specifically talking about patients with a medial tibial defect in varus knees. And sometimes you have to make a decision where you cut all the way down to the depth of the medial tibial defect, or whether you stop short of that and leave a little bit of a defect on the medial side in order to use a smaller insert. And Dr. Scuderi would usually leave the defect there and use a short stem on the tibial side. And I asked him once, I said, Dr. Scuderi, why do you choose to use a short stem, leave a little bit of a defect, and use a 12 insert versus cutting down a little bit further so we'd have a nice flat platform on the top of the tibia like we like to have, and using a 17 insert? And Dr. Scuderi, for any of you that know him, he has an answer and a reason for everything he does all the time. Even the things that seem kind of insignificant, he always had an explanation for things. So I would always like to pick, and I still do, like to pick his brain about things like that, to see what experience he had that led him to that. And to my surprise, he responded with, dealer's choice. And I went, whoa, like he never said dealer's choice about anything. So that got me thinking, like, well, does it even matter then? If Dr. Scuderi, who has a reason for everything, tells me it doesn't really make a difference, then is there a difference between using a 12 insert or a 16 insert? And if so, what are those? And then in my own practice, I had a lot of those similar type decisions. Sometimes where I would have a knee with a pretty significant deformity, I'd make a big medial release in a varus knee, and I'd end up with a 16 insert. And I started to think, man, could I have done something differently to make that not have such a big insert? And I started to not care about it after a while. I thought, you know what, it is what it is. Patients are doing well, whatever. But then, when you talk to reps, when you talk to other surgeons, well, you might not want to do this because then you can end up with a big insert and you don't really want to do that. So I started thinking, well, why don't we want to do that? And as anything, before I go and get too dogmatic in my own thoughts, I tried to look at the literature and see if there were any guidance that we could have in the literature. And there is some suggestion in the literature, including a couple references that we use in this paper about a little bit worse outcomes if you have a larger polyethylene insert. And I think the failures and the problems with higher reoperation rates in people with larger inserts was instability. That the thought was that the larger inserts were put in because that the patient's knee replacement was unstable. And I totally understand where people are coming from with that if you have to put in a large insert in order to deal with some, varus valgus or flexion extension instability or mismatch, then obviously that's a problem. But in my own experience, I felt like the people who I was putting larger inserts in, it wasn't because I was chasing, a medial side that I'd over released or some other instability that I couldn't take care of. It was just I was happy with the balancing. I put in the trial implants. I thought that was good, and I sized up until it bounced, and it balanced perfectly with a 16 or an 18 as opposed to an 11 or 12. So after putting all that together in my mind, I eventually said, you know what, to me, I don't really think it matters that much. So let's go to the data and see if it makes a difference. So that's kind of where the background and my own experience, where that came from, both in training and my own experience to get us to doing this study.
Now, moving on here, going to the methods, what specifically were you looking at, and what was overall the methodology for this study?
So we decided we wanted to look at whether or not the patients had a large insert, a medium insert, or a small insert, and we started to play around with, well, where would we set the limits for that? So with the system I use, it goes in 1 millimeter increments from 10 to 14, and then it goes in 2 millimeter increments, 14, 16, 18, 20, when it gets into the larger thicknesses. So we had to set the bounds around what is a small, medium, or large insert somewhere. So we ended up separating them into groups of small, medium, large, with small being less than 12 millimeters, so a size 10 or 11, the medium group being size 12, 13, and 14, and then large, anything over 14. And that's how we chose to separate the inserts that we got out. And then we had to figure out what factors associated with the patient preoperatively led to using a small, medium, or large insert. And for me, there's a couple things at play. One is alignment. The bigger angular correction that we need to make, the more likely are to need soft tissue release procedures to achieve ligament balance and larger gaps that you're potentially going to have. So I wanted to look at the patient's preoperative limb alignment, and I wanted to look at whether or not they had ligament releases and whether or not they had those factors had an effect on whether or not we used a small, medium, or large insert. And then I also wanted to look at, once we got done, we got a good total knee done with a small, medium, or large insert, was there a difference in patient outcomes? Was there a difference in range of motion? Was there a difference in KOOS scores? And we looked at that at multiple time points.
Now, you kind of touched on it when you were going through the methodology there, but can you spend just a couple minutes summarizing and going over your hypotheses for this study? And you talked about ligament releases as it related to polyethylene insert sizes and even resections and how those are all associated with each other. But what were your thoughts before the study as to what you may think you would find with this study?
So with the previous studies as a background that showed that there were higher risk of reoperations and poorer outcomes with larger inserts, I didn't feel like that was my own experience. So my hypothesis was that for a single surgeon using the same alignment techniques, using the same implant system, the same soft tissue balancing parameters and methods, that I should be able to achieve a balanced arthroplasty regardless of what the regardless of what the insert size is. So in my opinion, I did not think that it was going to matter as far as the outcomes go, whether I used a small, medium, or large insert. So my hypothesis was that there was going to be no difference between the small, medium, and large groups. However, I did think there were preoperative factors, limb alignment being one of them. People with larger deformities going to need a larger angular correction, more likely to need soft tissue balancing procedures, which can lead to larger gaps and a larger insert. So I thought patients who have larger degrees of deformity and patients who had ligament releases would be more likely to have a larger insert than if they didn't have those things. And then post-operatively, I thought there would be no difference in the patient range of motion and outcome scores based on whether they had a small, medium, or large insert.
Before we move on to the results, just one quick question for you. When you said that your hypothesis was that there were not going to be differences based on insert size, but the previous literature on this topic shows that there's different outcomes, specifically potentially higher revision rates for higher or larger insert sizes. What's the rationale? You don't have to give an exact quote for the previous studies, but what does the literature point to as the reason why that is the case?
So for those of us that do a lot of total knees, we've all been in a situation where you make cuts and you think, gosh, I made my cuts a little bigger than I wanted to in a specific place. Maybe I undersized a little bit. Now I have a big flexion gap that I can't match with extension. Or maybe I already took a couple extra millimeters of bone and extension to try to deal with a flexion contracture, and now I'm dealing with hyperextension. Maybe you made a ligament release and on the medial side to correct a varus knee, and now you're dealing with a 2 or 3 millimeters of looseness on the medial side that's not there on the lateral side. In all those situations, one of the ways to try to handle that, and one of the ways that people unfortunately do, is try to stuff more plastic in there. If I can just get a thicker insert, if I can tighten things in all directions, maybe I can take care of the problem that I created with either over resection or poor ligament balancing or flexion extension balancing. And I think that's why there is previous study that has shown higher failure rates, larger revision rates with a large insert. And because I think that if you're doing a larger insert in order to make up for a soft tissue balancing problem that you know that you have, but it's hard to correct, and you're trying to stuff more plastic in there and take care of it, then I think that's potentially going to be a bigger problem. Versus if you do the same alignment parameters, the same soft tissue balancing, you achieve the same amount of balancing, and it just takes a larger insert to do it, which I believe that in my single experience, consistent ligament release strategy, consistent implant strategy, I think if I use a larger insert, that it's probably just because there are factors at play that would need it.
Now, earlier you had mentioned preoperative deformity. So my question for you is, why would that matter, and how did you assess that with this particular study?
The larger deformity that you're dealing with, sometimes you have to make larger differential resections. So if, for example, in a valgus knee, you usually will be taken quite a bit more medially than laterally to take the distal femur out of valgus, versus in a varus knee, a lot of times those resections are about the same. And if you have good alignment, good ligament balancing, then you're taking pretty symmetric resections. So the bigger deformity you have to correct, it does change your strategies with regard to ligament or to bone resection. So another way we looked at this study was there a difference if we separated our patients into preoperative alignment groups where they were neutral, or if they were varus or valgus, would that have an impact over whether or not they needed soft tissue balancing procedures? Would that change the resections, and would that lead to a difference in insert sizes? So to do that, we considered patients neutral if they had 3 to 7 degrees of valgus. We considered them having valgus alignment if they had greater than 7 degrees of valgus alignment, and we considered them varus if they had less than 3 degrees of valgus. So that's how we separated those groups out to try to ascertain, does a bigger deformity lead to differences in consistent bone resections and potentially insert size and outcomes. And then I always measure my resections during surgery. So a caliper measured the distal femur, the posterior femur resections, the anterior femur resections, and the tibial resections. And we wanted to see if there was any differences in those bone resections that we made based on these alignment and ligament balancing and polyethylene size parameters.
Now, you kept mentioning consistent ligament balancing procedures and alignment procedures. So can you go into what that looked like with this study and how that may affect things?
Yeah, absolutely. So I'm always looking for mechanical alignment. I know there's been a big push to kinematic alignment to maybe leave a varus knee and a little bit of varus, a valgus knee and a little bit of valgus. We talked to Steve Howell earlier about kinematic alignment. We also talked to Gil Scuderi, as I mentioned before, about mechanical alignment. So if you're interested in those topics, go back and check out those episodes. Those were great. However, myself, I trained with Gil Scuderi, so mechanical alignment, is really the bedrock philosophy of the Insall Scott Kelly group that I trained with. So I'm always trying to hit overall mechanical alignment at 0 degrees. And because of that always drives that I have a consistent goal there. As far as soft tissue balancing goes, if I have a varus knee that I need to do a medial release, I still do those with a 3/4 inch osteotome down the medial tibia to release the MCL if I need to. On the lateral side, I'm a little more selective with soft tissue releases with an 11 blade with multiple perforation techniques. So making multiple perforations in the lateral structures, whether it be the IT band, the lateral collateral ligament, whatever it is that we're talking about, and doing kind of sequential releases on the lateral side with an 11 blade. So that's really the main differences on how I do the balancing and what I'm trying to achieve.
So now that we know how you did the study, what were the results that you found with this one?
So for our population, we had 437 patients that we had both preoperative and postoperative radiographs, and there was no differences statistically in postoperative alignment based on preoperative alignment or insert size. So if we looked at the patients after surgery, we were able to get consistent postoperative alignment regardless of what insert size we used and regardless of what preoperative alignment the patient has. So, where I talked just a minute ago about consistent ligament balancing philosophies and consistent alignment philosophies, those did play themselves out, that the postoperative alignments weren't any different because of that. If we looked at the small, medium, and large inserts, the patients with small inserts were statistically significantly less likely to have a ligament release than the medium and large groups. So as we thought, less likely to have a ligament release means less likely to have a large insert. Similarly, patients that required ligament releases were more likely to have larger inserts, and that was another statistically significant relationship. So again, as we had hypothesized, patients that had ligament releases were more likely to have a big insert. When we looked at alignment, when we looked at neutral postoperative alignment, those patients were more likely to have small inserts than patients with either varus or valgus knees. The majority of the malaligned knees were varus, 350 knees were varus, 49 were valgus, 38 were neutral. But among those, the patients who had more normal alignment, where we didn't have much of an angular correction to do, those patients were more likely to have small polyethylene inserts than the varus and valgus group. Posterior slope was another thing I guess that I didn't mention in the methods section. We did look at that as well, and the reason I didn't mention it is because it wasn't important. We did not find any statistically significant differences based on preoperative posterior slope measurements and insert size. When we looked at the resections, this is where the data got kind of interesting for me as well. We did Pearson correlation analysis for the preoperative alignment and whether or not it was correlated with the bone resections. And when we looked at that, we found a statistically significant correlation most strongly with the medial tibial and lateral femoral and tibial resections. Patients were found to have less resection with more deformity, and that's specifically those medial tibial defects that we're talking about, that when patients had a large deformity, they were more likely to have a smaller medial tibial resection, but the lateral tibial resection was the same. So as I talked before, when we have consistent alignment philosophy, I would get to where I had a consistent amount of resection on the lateral side, and then the tibial side may take 4 or 5 millimeters. It may undercut by 3 or 4 millimeters. But I had a pretty consistent resection laterally, and the medial tibia was variable depending on how much deformity the patient had, with less tibial resection correlating with more deformity. On the lateral side, those patients had more lateral tibial and lateral femoral resection if they had larger inserts. So really the same relationship held when patients had larger deformities, and the majority of these were varus knees. We would take a little bit less medially, a little bit more laterally. And we're talking about the differences were about like 1 to 2 millimeters difference. So it wasn't a large difference, but it was a statistically significant relationship that as the deformities got larger, we took less medial tibial bone, more lateral femoral and lateral tibial bone to make that angular correction. And then when we looked at postoperative range of motion, we did not find a difference between the insert size groups at any interval. So whether the patient had a small, medium, or large insert did not affect postoperative range of motion. And the same is true of postoperative outcome scores with the KOOS. So when we looked at postoperative KOOS scores, there was no statistically significant difference between insert sizes at any time point. Last but not least, we looked at subsequent procedures. There were 10 subsequent procedures performed after these total knee replacements, only one of which was a total knee revision, and there was no difference found between the insert size groups. So when we look at the results kind of in totality, confirmed a lot of the relationships that I felt like we were finding just by my experience. We put it to the test of data collection, and it seems to be lining up in that manner.
That's clearly a lot of information and a lot of good, helpful information. And I remember going back and forth with you on this study when we did it. It was a doozy then, and hearing it back is a doozy as well. So with all of that, you talk about in the totality of the data, what's the biggest takeaway from a clinical relevance piece with this data?
Well, I think first and foremost, the biggest thing that we were going after was, do patients do differently post-surgery if they have a small, medium, or large insert? So the surgeon, can they say, well, I'm worried about this knee because it's got a 16 insert versus I'm not worried about this knee because it has an 11 insert? And the answer is no. We did not find any statistical correlation or any kind of a statistically significant reason that would back up that worry or feeling good or bad about either of those situations. That if you get the knee well aligned, you get the knee well balanced, that the amount of plastic that you put in does not matter for revision rates, doesn't matter for range of motion, does not matter for your outcome scores. And I think that's a pretty significant finding. One, given the fact that there have been previous studies that have shown that it does matter, and we say that it does not. And two, just again, really highlighting consistency with implant choice, alignment philosophy, and ligament balancing and polyethylene insert. If you're consistent across all those, then the insert size really doesn't matter. And then so if we think that doesn't matter for outcomes, then we still got to try to figure out, well, why do we end up with one group of patients being larger inserts and one group of patients not being larger inserts? And since the majority, I think this really hones in on varus knees, because as I said before, 350 of the 437 patients had varus knees, 38 were neutral, and 49 were valgus. So the vast majority of these patients, 350 out of 437 were varus knees. And if we take a pretty standard level of lateral resection, or I guess to back up a little bit, if the larger correction is going to lead to less medial tibial resection, more lateral femoral and lateral tibial resection, and those are the statistically significant differences that we found. And with that, though, does come larger inserts, more likely to have ligament releases. So I think we can draw a line now with all this data as we try to take something away from it, is that the patients who have a larger deformity have a larger correction and a little bit different bone resections. You're more likely to need a ligament release, and that leads to a larger polyethylene insert. However, it does not impact the ultimate outcome with range of motion, reoperation rates, or functional outcome scores.
Now, with the main finding of the fact that there is not any differences in terms of range of motion and outcome scores and those types of outcomes when it comes to polyethylene size, in this particular study, now you mentioned in previous literature, there has been studies out there that have shown a difference based on insert size. And anytime, I don't care what you're talking about, but let's stick with this topic specifically, you get to a study that shows a difference and one that doesn't. I noticed you mentioned consistency in terms of ligament rebalancing and alignment procedures and those types of things. And again, that gets back into the methodology. So what's your takeaway in terms of why no difference here versus there's been shown to be differences in other studies?
I would argue that the reason we found no difference is the consistency across multiple different parameters with alignment, ligament balancing, and technique. Consistent implant, consistent technique leads to consistent results. And if you have a group of surgeons that all do things a little bit differently from an alignment perspective, from a ligament balancing perspective, from an implant design or implant choice perspective, then you may be more likely to find differences based on polyethylene insert size. I think the other thing that really highlights for me is the importance of measuring bone resections. I know it takes a minute or two to measure your bone resections, but I feel like I've learned so much about my own technique and honing my own processes by measuring my resections. I would not know this information if I didn't measure my resections. And the other thing that I think it highlights is to be critical of yourself and look at your own data. So if I have a big varus knee and I make my resections and my medial resection is 6 and my lateral resection's 12, now I know that I've taken too much bone. And when I end up with an 18 insert in a patient like that, I know that's on me by measuring my resections. I can very easily figure out if instead of taking 6 and 12, if I'd have taken 2 medially and 8 laterally, I would have ended up with a more reasonably with a smaller insert. That I can draw a straight line to my own technique leading to the bigger insert, even though it doesn't cause a significant difference in outcomes. Versus if you make the same resections, if I take on the tibial side, 2 and 7, which are pretty thin resections, and when I do my balancing and everything, I end up with a 16 insert, I don't care. I can very easily look back at my resections and think, I am not here with a big insert because I cut too much bone on the tibial side. You only really get to hone in on those things and figure out what makes the difference if you measure your resection. So it's something I learned as a fellow and that I would encourage everyone to do.
Just an interesting point there. You talked about two different things, and it reminded me of the robotics episode that we did a couple months back, where you talked about, the take-home message with that was measure your own resections and follow your own patients and look at your own data, and you can be critical on the differences between standard procedure versus robotic procedure. So with that being said, with robotics, this patient population goes back multiple years, and I know you haven't been using the robot for this long a time, but did some of the rationale or reason behind why you wanted to look at this, did that have anything to do with having more data from the robot or knowing you were getting a robot at this time, or would you have done this study regardless? And follow-up question to that would be, would the robot change any of this data if you had, fast forward in the future 5 years or so, and you took some of these same parameters? Do you expect anything to be different with robotics versus standard instrumentation?
So the answer to the first question is the decision to do this study really didn't have anything to do with robotics. It was just a curiosity of mine. There were some things that people seemed to be worried about in the OR that I, with my own experience, wasn't worrying about. Seemed like people were concerned about a 16 insert or an 18 insert, and I was unconcerned about it, and I wasn't seeing a problem with it. So I had to look at my own data to try to figure out, well, if that's the case, why am I worried about? Why are other people worried about it and I'm not? And what am I doing differently? What could I be doing differently? So I wouldn't say that robotics had anything to do with that. I do think that my resections have changed with robotics, and I think I'm more cognizant now of the effect of my posterior resections on my flexion gap, which is something that people talk an awful lot about when you get to talking about measured resection in robotics, is really dialing in that flexion extension balancing. And it wasn't something that I spent as much time on before. And honestly, I don't think it was a problem. I wasn't having a bunch of patients come back to the OR for revisions for instability due to that, and I wasn't struggling to get people balanced. But I have been surprised as I moved on to the robot. Sometimes the resections are ones that I definitely would not have taken. So, for example, there have been times with the robot that I have taken that the robot has told me I need to take, like on a varus knee, 6 millimeters medially and 10 millimeters laterally in order to get to a 10 insert, a pretty thin insert. And I was worried about that at first, but I kind of went with it, and it seemed to match up. That even though I was making a larger than normal resection on the tibial side, that my insert was still pretty small. So I thought about, after that experience, what would I have done had I not had the robot? Well, I would have cut it at 2 and 6. I would have taken less bone, and then I wouldn't have had enough of a gap, and I would have had to go back and recut. And that's where the efficiency piece, I think, comes in with the robot, and in being able to achieve balanced flexion extension spaces with one cut instead of multiple cuts. I also think that my component size on the femoral side has gone up with the robot. I think I'm taking less bone posteriorly, which has led to larger femoral components, and I'll be interested to see what that looks like when we look that up. I also think I'm going to end up with fewer larger inserts. I think the robot has helped me dial in those alignments and things on the first time around, rather than having to make multiple cuts and correct things. So I think what the robot's probably going to show me, or the measurements are going to show me with the robot, is that I take smaller posterior resections, similar distal resections, and that I have larger femoral components and smaller polyethylene inserts on average. But more to come. We'll look at that. That's a future direction we definitely want to go with a similar study such as this with robotics.
Well, excellent. I appreciate you going over that. It's a great study, and as you had highlighted, really shows some good clinically relevant data. So I appreciate you going over that project. As always, if you want to get a hold of us, you can hit us up on our Twitter and Instagram pages at the SKC Podcast. You can visit our YouTube and Facebook SKC Podcast pages, or you can email us at the SKC Podcast at gmail.com, and we will talk to you guys next week.